Welcome to the Voice of Stroke podcast, your fast, reliable update on the science driving stroke care forward. Brought to you by the European Stroke Organization.
In this episode of Voice of Stroke, we're staying close to home. 3 new papers, all interrogating the edges of endovascular thrombectomy for large vessel occlusion, or LVO, stroke. Efficacy is no longer the question. What these 3 studies push on is patient selection and treatment intensity at the margins. We'll look at 3 questions. First, once you've achieved an angiographically successful thrombectomy, is there value in adjunctive thrombolysis on top? Second, is there a point at which a stroke has done too much damage for thrombectomy to be worth attempting at all? And third, in the extended time window, does time from stroke onset still matter, or have we moved beyond time is brain? Let's get started. Our first paper is Choice 2, published in JAMA. Even after angiographically successful thrombectomy, a meaningful proportion of patients still have poor functional outcomes, a gap partly attributed to incomplete microvascular or tissue-level reperfusion, despite successful macrovascular recanalization. Choice 2 asked whether adjunctive intra-arterial alteplase, on top of an already successful thrombectomy, could close that gap. This was a randomized, open-label trial with blinded outcome assessment, run across 14 stroke centres in Spain. Investigators enrolled patients who had achieved near-complete reperfusion, an E-TICI score of 2B to 3, and randomized 440 of them to either a low-dose intra-arterial alteplase infusion on top of thrombectomy, or thrombectomy alone. The results were striking. At 90 days, 57.5% of patients in the intra-arterial alteplase group achieved a modified Rankin scale of 0 or 1 versus 42.5% in the thrombectomy alone group, an adjusted risk difference of 15%. Imaging supported the mechanism with substantially less residual hypoperfusion after alteplase. Importantly, this improvement did not come with a significant increase in symptomatic intracranial hemorrhage, 1.4% in the alteplase group versus 0.5% in the thrombectomy alone group. But there's a catch, and it's an important one for practice. 90-day mortality was higher in the alteplase group, 12.1% versus 6.4%, an adjusted risk difference of nearly 6%. This mortality signal contrasts with the broader trial evidence. A 2025 meta-analysis pooling 6 earlier randomized trials in nearly 2,000 patients found no significant increase in 90-day mortality with intra-arterial thrombolysis after successful thrombectomy. So we have a treatment that improved functional outcomes, but with an unexpected mortality signal that the trial authors themselves say warrants further study. Before this changes practice, that signal needs to be better understood, ideally through individual patient data pooling across trials. Our second paper, published in Stroke, flips the question around. Instead of adding more treatment, when should we be withholding it? Pivotal large core trials selected patients using ASPECS, the Alberta Stroke Programme early CT score. But ASPECS is based on which brain regions show early ischemic change, rather than directly measuring infarct volume, so it may not accurately reflect the true infarct burden. Using a nationwide prospective registry and stroke neuroimaging repository from Korea, this study asked whether directly measuring ischemic core volume could provide a more precise guide to prognosis and treatment benefit. The investigators assessed ischemic core volume using diffusion-weighted imaging, or DWI CT perfusion, and non-contrast CT. Definitions of a large core varied by imaging modality. An ASPECS below 6, at least 50 millilitres on DWI or non-contrast CT, or at least 70 millilitres on CT perfusion. Among 552 thrombectomy-treated patients, ASPECS and direct volumetric assessment frequently disagreed about who actually had a large ischemic core. Importantly, when ASPECS suggested a large core, but DWI volumetry did not, outcomes were similar to those of patients classified as having a small core by both methods. Poor outcomes of modified Rankin score of 5 or 6 at 90 days occurred in 11.8% versus 11.7% with no excess risk after adjustment. By contrast, when volumetric imaging confirmed a large ischemic core, the prognosis was consistently worse, regardless of the aspects classification. In head-to-head comparisons, DWI volumetry was particularly informative. It was a strong independent predictor of poor functional outcome, with an adjusted odds ratio of 6.28, and it outperformed aspects in predicting which patients would do poorly. The authors then used target trial emulation to ask a different question. How does the benefit of thrombectomy change as ischemic core volume increases? Among patients with a DWI core volume of 50 millilitres or more, there was a trend towards benefit with thrombectomy, although this did not reach statistical significance overall. But when patients were divided by ischemic core volume, a possible gradient emerged. Thrombectomy appeared beneficial between 50 and 110 millilitres, but that benefit was no longer evident at volumes of 110 millilitres or greater. That raises the possibility of a therapeutic ceiling somewhere around 110 millilitres for DWI, but this should not be interpreted as a definitive cutoff for withholding thrombectomy. The threshold is also likely to vary by imaging modality. Notably, a recent analysis from the Atlas collaboration suggested a different cutoff using CT perfusion. So while 110 millilitres may be a useful signal on DWI, it should not be viewed as a universal threshold, and these findings will need prospective validation. For now, the key message is that ischemic core volume may tell us more than aspects alone. Quantitative volumetry could help refine selection in large core stroke, particularly at the extreme end of infarct burden, where the likelihood of meaningful benefit from reperfusion may become increasingly small. Our third and final paper turns to timing, specifically the extended 6 to 24-hour window, published in Neurology by the AURORA collaborators. We already know thrombectomy is beneficial in this extended window, with advanced imaging selection. This meta-analysis asked a more granular question. Within that window, does time from onset still modify outcome? The team pooled individual patient-level data from 6 randomized extended window trials, including 505 participants with a median age of 70 and a baseline NIH stroke scale of 16. Of those, 266 underwent thrombectomy and 239 medical therapy alone. The key finding was a significant treatment by time interaction. Among thrombectomy-treated patients, longer time from symptom onset to randomization was not associated with worse disability or a lower likelihood of functional independence. The adjusted odds ratios per additional hour was 1.02 for disability and 1.06 for functional independence, with confidence intervals crossing 1. The pattern was different in the medical therapy group. As time to randomization increased, outcomes progressively worsened, including a significant decline in the odds of functional independence. Before we conclude that time no longer matters for EVT, the authors offer an important caveat. Among thrombectomy-treated patients, the total time from stroke onset to starting the procedure, or even to achieving reperfusion, was not associated with outcome, but this likely reflects the power of imaging-based selection. These extended window trials preferentially enrolled slow progressors whose brain tissue remained salvageable despite presenting late. Moreover, timing itself may also be imprecise, as last known well can substantially overestimate the true duration of ischemia, potentially weakening the observed relationship between time and outcome. Once those patients were selected, though, time mattered again. Longer delays from randomization to reperfusion were associated with worse disability and a lower likelihood of functional independence, with adjusted odds ratios of 0.58 and 0.51 for each additional hour respectively. In other words, whilst imaging-based selection may reset the treatment clock at the door, it doesn't stop it once you're inside. So the message isn't that time is no longer important. Rather, imaging helps to identify patients whose treatment window remains open, despite the hours already elapsed. Once they are identified, every effort should still be made to achieve reperfusion quickly. So 3 papers, 3 answers to the same underlying question of where thrombectomy's boundaries lie. To summarise, Choice 2 shows that adding intra-arterial alteplase after a successful thrombectomy can meaningfully improve functional outcomes, but the mortality signal means this isn't yet a straightforward win and needs to be weighed carefully, especially given it wasn't seen in prior trials of the same intervention. The Korean registry study reminds us that more precise, volume-based imaging can draw a sharper line around who is unlikely to benefit from thrombectomy at all, helping us avoid futile procedures in the most severely affected patients. And the AURORA pooled analysis shows that within a carefully imaging-selected extended window, onset time matters less than we might assume, but in-hospital delay remains just as dangerous as ever. Put together, these 3 studies aren't about whether thrombectomy works. That question is settled. They're about drawing its edges more precisely, how much treatment to add, which patients have moved beyond benefit, and which parts of the clock still count. As thrombectomy becomes more refined, so does the responsibility to select the right patient, at the right dose, at the right time.
That's all for this episode of Voice of Stroke, brought to you by the European Stroke Organization. You can listen to Voice of Stroke on all your favorite podcast channels, including Spotify and Apple. Visit the European Stroke Organization at iso-stroke.org for more information about our mission and key activities. My name is Linxin. Thanks for listening.